Okay, so hello everyone. It is my pleasure to welcome you to this AORTIC session in the London Global Cancer Week. My name is Fatima Cardoso. I'm a medical oncologist. I'm based in Lisbon, Portugal, and I'm a breast cancer expert and also the president of the Advanced Breast Cancer Global Alliance. I'm joined today by Francis Shanungondo. And Francis, would you like to introduce yourself, say a few words of welcome?
Yes, thank you. Yes, my name is Francis Chinagundo. I'm a consultant urological surgeon. I'm based in London. And prior to Fatima taking over, I was the AORTIC vice president for Europe. So my particular interest is in prostate cancer, but have a strong interest in global health and in particular cancer control. Thank you.
Thank you. So what we have chosen this topic on how to improve quality of cancer care without increasing costs, because we know that for all countries, not just low or middle income countries, but for all countries, savings in the costs of cancer control are an extremely important topic. But there are things that we can do to improve cancer control and particularly to improve quality of cancer care that are cost effective and that will not increase the costs. Most of them will even lead to reduce the costs because they will be more cost effective and avoid duplication and perhaps wrong use of resources, both human resources and financial resources. And the issues we'll be discussing today is around this topic. What can we do from prevention to end-of-life care in the sense of improving quality without increasing costs beyond what is possible for any type of country around the world. So we have 4 excellent speakers to whom I already thank for their acceptance to be here and for their talks, which I know will be great. And also thank you to Dr. Shinengodo for co-chairing the session with me. And before I forget, also thank you to all the AORTIC Secretariat for all the support to organize this session. So I think we will start. We will have the 4 talks, and then please send in all the comments and questions that you want via the chat, and we'll have plenty of time in the end to go through the questions and to discuss among panelists and chairs. Thank you very much once again for being here. And Francis, over to you.
Yes, thank you. So I'd like to introduce our first speaker, who's hot-footed it from another session. So thank you, Ben, for that timekeeping. So I'd like to introduce Professor Benjamin Anderson, who is he's from Washington. He's a professor of surgery and global health at the University of Washington. His clinical practice is predominantly to do with breast cancer. He's published extensively on oncoplastic procedures, breast conservation surgery. He's a past president of the Society of Breast Disease and currently serving as vice chair of the National Comprehensive Cancer Network Breast Panel. And he's also been a strategic advisor for the National Comprehensive Cancer Network since 2016. He's a recognized leader internationally in global cancer control. He did found the Breast Health Global Initiative, which has a particular interest in how you deal with breast cancer in resource-strapped countries. So thank you very much, Ben, for your forthcoming contribution.
Well, thank you very much, Francis. I appreciate the kind introduction. And as Francis alluded to, we're going to be talking about the work of the Breast Health Global Initiative in developing resource stratified guidelines and guidance, because what you do with it is what matters, and referencing this from the perspective of the World Health Organization, where I'm working currently. Can someone indicate, are the slides looking correctly? Flag me, great, thank you. So the Breast Health Global Initiative was jointly founded by Fred Hutch and Susan G. Komen for the Cure. Now I'm with WHO based in Geneva. What I'd like to do is first talk about evidence-based resource adaptation. How do we think this through? Ideally, we would prevent cancers from occurring in the first place. But if we're not successful in doing that, we need to go through this sequence of early detection, diagnosis, and treatment. That was the basis of our original work, recognizing that you need to have healthcare systems that will support that system working in a functional way. And we actually first went to Ghana in 2004 as a beginning point, and I can say that we know that life began in the African region. Well, so did resource stratified guidelines, because this is where we really did our key work and recognition. This is the Confanoche Teaching Hospital back in 2004. This is the breast clinic that we visited. And this patient had the earliest breast cancer that I saw when I was in that clinic. If you look at the diagram that the surgeon drew, Michael Ohini-Yaboa, you can see that there was a 10-centimeter mass. But what much more common was this sort of cancer, locally advanced disease, where supportive and palliative care was really the mainstay. They did have a multidisciplinary clinic, and the gentleman that you see in the front was the one pathologist for that 1,000-bed hospital. The lady to his right was the one radiologist for this 1,000-bed hospital. And that created very significant obstacles. Advanced stage diagnosis, mastectomy being used without the corresponding adjuvant therapy, at which point you can anticipate you will not impact upon outcome in terms of survival. And because there was one pathologist for the 1,000-bed hospital, a path report would take 4 to 6 months to generate. This was true both at Confanoche and Corlebu, the two leading teaching institutions. And that was the genesis for recognizing there's some resources you must have in place where the system cannot function. That would be included with a pathology report. And that was the basis of the development of resource stratified guidelines. So what we did through BHGI is we held this series of global summits. Many of the people involved today were part of these. And each time we took on a different topic. We modeled this after the NCCN panels and tried to address this, what are the core questions? And this idea of resource stratification was that you need to be able to take the standard resources and put them in an order. If you look at NCCN standard guidelines or ASCO or ESMO, they assume you have all of the tools. What it doesn't give you is a prioritization scheme if you don't. So basic level resources like pathology, those are the ones that if you do not have this, you really shouldn't start. You should go straight to supportive and palliative care. Limited level, we defined as those resources that would make major improvements in survival. Most of our systemic therapies fit in this group. Enhanced level, we defined as those resources that might not improve survival, but would make other important differences, such as breast conservation therapy. Doing a lumpectomy with radiation is equivalent to a mastectomy, but it does not save more lives. It does improve acceptability. And we also have to recognize there's some resources you should not focus on. We tend to talk in our Western European and North American meetings about PET scans and MRI and the most exciting cutting edge technology without asking the question, is this where you start? And do we actually save lives? Actually, no one has lived longer because they had a PET scan. And so that's why it takes a lower level prioritization. So what we did in this work was we just took the standard tools and we laid them out in that 4-tier system, looking at healthcare systems, early detection, diagnosis, and treatment by stage, and we just mapped them out in that fashion. And that was the basis for this. In the beginning, everybody told us all the reasons why they could never do this, why this was a bad idea, the certification of substandard care. That was not the concept. The concept is, how do you build in a logical way? Let us take an example of screening. So we have this evidence that mammographic screening used in women ages 50 to 69, perhaps extended to 45 to 74, that will improve breast cancer mortality by 20 to 23%. And I think we mistakenly then indicated that, well, that's where the rest of the world should start. And that's like saying everyone should start with Pap smears rather than thinking of more innovative approaches, because the resources for mammographic screening are so intense. Actually, the basic level resource is taking a history and doing a physical. The limited level resources are diagnostic imaging. If you can't diagnose disease, this idea of screening is really much more resource intensive and problematic. And so considering the order is part of what we do. That is why WHO has been focused in saying, in this early detection scenario, rather than just talking about screening, where you screen 1,000 women to do a diagnostic workup on 150 to find 7 cancers, that we begin with early diagnosis. How do we find the women and get them into our system when they have early palpable findings? 2-centimeter masses rather than the 5-centimeter ulcerated mass. That's the beginning point. And if you can't work up the cancers that you can see or feel, you're certainly not prepared to start with screening where you can only see them on a computer screen. But the question was, is it too late? If you wait till they have symptoms, have we gone too far? Well, now we have data from India that says no. Actually, you can improve mortality with clinical detection. Cluster randomized trial, randomizing women to clinical breast exam screening versus awareness education. And they did in fact see both stage shifting, the downstaging of disease, but they also saw survival benefit in women 50 to 69. This is not an argument against mammography. This is a point of you start with clinical interventions before we move on to the imaging ones. We have to put them in a sequence. And we add the same thing with treatment. What are those fundamental treatment strategies that we should be using, which of course would be the modified radical and our basic systemic therapies. So what did WHO do with this work? In 2017, with the leadership of Dr. Andre Obawi, we passed the initiative that put resource stratified guidance onto the radar screen. And so now WHO is called upon to use resource stratified guidance and also collaborating with other organizations to use cost-effective strategies. So thinking beyond the data into healthcare systems. So I want to then touch on, well, what has happened with this work? The idea of resource stratification is it's a concept, it's an approach, it's not a magic guideline. I don't think there is a magic guideline. But NCCN is one of the groups, along with ASCO, that has actually adopted resource stratification as part of their work. And so they created the resource stratified guidelines for a large group of cancers. But what I think was most important was NCCN went to Africa and helped working with the American Cancer Society and IBM and CHI, that they created this group that then asked, how do we actually apply this in Africa? And the harmonized guidelines, working with these multiple organizations, was to say what is appropriate for us based upon this in our environment. And we now have published the harmonized guidelines for sub-Saharan Africa that was created by experts from Africa to answer the question, what would we consider the standard of care? I think this is a really important step and strategy going forward. NCCN now has over 46 published guidelines for sub-Saharan Africa using this resource stratification. But I want to make a point here, and that is that a guideline is not an endpoint. The guideline is a beginning point. And perhaps even more important, the question of which guideline did I use is, can I follow the guideline? Because if only 20% of the patients receive the care that is defined through those resource stratified approaches, then we really didn't target it correctly. It's following all the way through that matters. So we worked with CCAN to help develop a guideline development approach. Again, the concept here is that it's a framework for health system strengthening. We want to avoid unrealistic targets that are aspirational but not likely to take place. And we recognize that this is an iterative, repeated process, that we're never done. We're always looking for new approaches based upon multidisciplinary planning, gap analysis, where are the holes that we could realistically fill, and you have to assess feasibility and sustainability. If we go do a project If when we leave, whoever we is, when we leave, if the project stops, that is the definition of failure, that it has to be sustainable with existing resources. And so that moves us to the final topic, which is the Global Breast Cancer Initiative. This is the initiative that WHO launched, and we're about to come out with normative materials that will help express what I will briefly describe to you here. The overall objective of GBCI is to reduce breast cancer mortality by 2.5% per year. Because if you do the math, that would save 2.5 million lives over a 20-year period. There are 3 pillars to this approach. The first is health promotion for early detection. The second is timely breast diagnostics. And the third is comprehensive breast cancer management. And each one of these is amenable to a resource stratification approach. We always have to be thinking about existing resources. This is marrying the public health sciences approach, where we think in terms of populations, and the clinical approach, where we manage patients one step at a time. I want to touch on just a few key points that we have observed. When you look at the countries that have succeeded in reducing breast cancer mortality, that overall drop has been 40% in Western Europe and North America. That's a 2 to 4% drop per year. So 2.5% is not unrealistic. But the countries that did this had higher universal health coverage rates and also had better access as counted by the number of public cancer centers. So one of the metrics that we need to be thinking about as we think through this realistic application is there funding and is there access? Without those, you cannot anticipate mortality to benefit. But if we do have these things, our data from ABCDO, the African Breast Cancer Disparities and Outcomes Study, shows that by improving treatment, by downstaging disease, by reducing inequities through that access, those colored bars, the green, red, and yellow, that's how much improvement could be seen in sub-Saharan Africa in those countries with real-world data from there. But we have to remember that in order for this system to work, we have to follow our treatments through to completion. So one of the key indicators that we have for ABCDO, and it gets to this guideline adherence concept, is that the metric of following treatment through all the way without abandonment, our target being 80% of patients to have that. Because when we actually look at the data of what has taken place in these 5 sub-Saharan African countries where the outcomes were measured, of the patients that began their systemic therapies within 3 months, it is only about half that made it all the way through. And so we talk about access to drugs, we talk about, can you get trastuzumab? Can these available? Obviously important questions, but if they cannot be administered all the way through to completion, we won't see the benefits. So in summary, we now have UN mandates that puts non-communicable diseases, which includes cancer, onto the global health agenda. And that's why we're able to talk about this from WHO headquarters, working with their regional offices and national offices. We see breast cancer as this index malignancy for organizing health systems, for thinking through our approaches for early detection, diagnosis, and treatment. Underlying that is the resource stratified guideline approach and adaptation. These resource stratified guidelines provide a framework for evidence-based implementation strategies, and it should be guided by implementation research. Measuring our outcomes is not optional, it's not an add-on. It has to be built into the system so we can actually know if we're making successful improvements with the interventions that we do. As such, we believe that the Global Breast Cancer Initiative can be a catalyst for change by developing approaches that are relevant to women's cancers and women's health throughout their life continuum. I would like to acknowledge the very awesome support of the Department of Non-Communicable Diseases at WHO under the leadership of Dr. Bente Mikkelsen. Thank you very much.
Thank you very much, Professor Benjamin, for that talk. I wasn't familiar with the Global Breast Cancer Initiative, but I am now, and it's instructive to see, the steps by which that came about, and I look forward to the implementation and the reduction in breast cancer mortality, particularly in sub-Saharan Africa, which is AORTIC's focus. So there will be an opportunity to ask questions when all the 4 speakers have been through their presentations. So what I'd like to do now is to ask Fatima to present our next speaker.
Thank you. And thank you, Ben, for summarizing years of work in 15 minutes. So it is my great pleasure to introduce Peter Verustek. I'm practicing his name since this morning. So originally from Belgium, Peter is now in Botswana, where he is the Global Outreach Facilitator at the Botswana Rutgers Partnership for Health. He's also a senior lecturer in oncology at the School of Medicine, University of Botswana. And he is providing an incredible work there, training and moving forward the clinical research as well as the clinical practice in Botswana. So after working for more than 20 years in Namur in Belgium, he and his family moved to Botswana, and we'll be very interested to hear his thoughts about the issue of preventing when it's possible and treating early always. So Peter, please, and thank you for accepting our invitation.
Thank you, Fatima. Good afternoon. I'll start with some sad news. Cancer in Botswana has become the major cause of mortality in people and patients living with HIV. About 70% of those patients present with locally advanced disease, and we are struggling. We don't have the drugs to treat them, not even the basic drugs. So we have to do something about that. First of all, I'll give you the bigger picture of cancer in the world and in Botswana, and then the potential ways to do it in a cost-effective way. Prevention obviously is the cheapest cure. Screening of asymptomatic patients, early detection of symptomatic patients, and then early treatment, if we can treat what we detect. So you've seen these slides very often, I guess, where we see that globally cancer is prevalent in 20 million new cancer cases per year and 10 million mortality cases per year. Now, the highest incidence of cancer, of course, is in the high-income countries, but the highest mortality is in the low and middle-income countries. About 70% of them are in the low and middle-income countries. And of those, 40 to 50% are cancer that are infection-related, and most of them are preventable. So prevention is the cheapest cure, particularly of those infection-related cancers. And you know that HIV is a risk factor for cancer. So keep HIV under control by all the means you can. And if you have HIV, keep HIV under control with the 90-95-95-95 target, which will also keep the HIV/AIDS virus under control, and therefore less Kaposi and less Castleman's disease. Start vaccination for girls and boys from 9 to 13. Boys are often forgotten in this, and a lot of African countries don't vaccinate boys because it prevents cervical cancer, but it also prevents ENT cancer, vulvar cancer, penile cancer, anal cancer. Those cancers the last three, we don't often see them in the high-income countries, but they're so frequent in the low and middle-income countries, particularly the HIV patients. And hepatitis B, that is a risk factor for HCC cancer, obviously. Go and vaccinate those children in endemic areas. But let's go to a broader way of preventing that is also cheap. Lifestyle change. It's hard. It's hard for the patient. More exercises. Start exercise programs in the villages. Eat more fruit and vegetables. Well, that's not always easy for everyone, because vegetables and fruit, and particularly vegetables, are expensive. Less red meat. That's a hard one. Like particularly here in Botswana, where the T-bone is so good. Less alcohol. I can't find another excuse for that. Less smoking, obviously. And use the money of those taxes on smoking to prevent and to cure. Let's go for screening. Screening of asymptomatic disease, right? Okay, let's screen everyone. Well, let's reflect on that first and look at the WHO criteria, how to screen. The screening program should respond to a recognized need, okay? It should have a defined target population, And there should be a scientific evidence that the screening program actually is effective. Don't jump on any new fancy device, right? It should, and also it should come with the care that is around it. If you can't provide the care, don't screen. There should be quality assurance, of course, and it should be culturally acceptable, and it should be equitable. It should be there for everyone, not only for the ones that are in the capital. And of course, you should not harm with that screening program. Where am I? Okay. So let's go for the most important one here in Botswana and Sub-Saharan Africa, cervical cancer. So we started doing cervical cancer screening in Botswana. In the beginning, there was nothing. And then from 2003 onwards, we did pap smear. We saw that it has an enormous implication for cytology and pathology, which was hard to meet. Then from 2012 onwards, we went to VIA, screen and treat with visual inspection with acetic acid, the vinegar test, right? Better than not doing it. Still, sensitivity is not very high. So therefore, ideally, we should go to HPV testing. But let's look at the reality on the ground. Only 10% of all the cervical cancers that we see in our cervical cancer clinic are screen detected. The vast majority are symptom induced. We did an interview on cervical cancer patients in our clinic, and only 24% in 2019 said that they ever had any form of screening. Very often because the patient was invited to, but was afraid of doing it, or said, I don't have symptoms, so I do not do screening. The time to results of screening, and particularly for pap smear, was about 200 days, not only because pathology had delayed, but also because the results came back late, or the patient didn't get the results in the right way. So for women living with HIV, they have more access to healthcare because they go regularly to get their drugs. So there's more awareness in HIV patients about cervical cancer, and therefore more regular screening because it's on their treatment sheet to see, hey, has screening been done? But despite, you would expect that there would be more early stages of cervical cancer when they are detected, like stage 1 and stage 2. But despite that, there's no major difference in stage at diagnosis in women living with HIV. So still a lot of work needs to be done in screening. So therefore, in the women living with HIV, we begin at the age of 25, and the goal is to move towards HPV DNA testing. But although the cost should be $10, the cost here is about $70. So that a lot of work has to be done on the costing. And still, there's a high percentage of HPV positives because the sensitivity is so high. So it very often goes with a second test. And you have to be able to implement that. So not only that, but any woman with a positive screen should be evaluated and treated if necessary. So those patients that you do leave on, see them back for a result after 3 months at minimum. Okay, that's not often happening. And if cancer, referred to a gynecology service. So let's move to breast cancer screening. So as Ben so beautifully said, WHO still recommends clinical breast exam for those countries that can't implement mammography. And the data are there, as he nicely showed them, with the India cluster trial, reduces of stage of diagnosis and reduces mortality, particularly in women over 50 years of age. So what about mammography and the other screening devices? Well, in Botswana, the extra benefit of over clinical breast exam by a trained healthcare worker is small. Probably you'd have to do 1,000 mammographies to find one that wasn't palpable. And even that palpable one, probably would be no proven survival compared to clinical breast exam. There was a Canadian study comparing clinical breast exam by trained workers compared to mammography. Didn't see that difference. And obviously we'll have a lot of false positives that you have to deal with extra exams, creating extra anxiety and extra burden on the health system and extra cost. And obviously that small lesion, unpalpable lesion, ideally you're treated with breast conserving surgery. Can you do that? Does the surgeon know how to do that? And can you irradiate that particularly lesion? Because you need radiotherapy then. And can you offer it to everyone? Very often that's not the case. So what's the added benefit of it? Of course, there's a cost. You need a radiologist, you need maintenance, you need radiographers compared to this expected outcome. And Botswana has roughly probably would cost about $4 million to implement this program per year, and that's more than the annual spending on cancer drugs in our country, right? So where is our priority? But obviously, it's a great for systematic screening, because you can always keep the images for review by second person, for example, in the country to clinical breast exam. Once treatment infrastructure is ready, and once you can treat what you can detect. And it is already applicable for those mammography machines that are there for yearly follow-up exams, for those that have cancer, breast cancer, for screening of high-risk patients, of course, and for those small CBE-detected lesions if waiting time is not too long. And I can't read that one. And then what about the eye breast? Well, it's probably also good, but again, you will detect a lot of non-breast cancers. And therefore, it would be probably a very good tool to train those healthcare workers that you want to train on clinical breast exam, because it will detect something and then you feel it. Oh, that's what I need to feel. So that's a good use of it, as long as the studies don't prove its superiority. So let's screen colon cancer. Let's screen prostate cancer. Well, colon cancer needs a screening test ideally with a fecal occult blood test. And if that is positive, it implies sigmoidoscopy or colonoscopy. Can we do that in our country? We can't for the moment in Botswana. Same for prostate cancer. You need to do PSA to thousands of people, and you need to repeat it. So it's a lot of infrastructure, a lot of cost, and it goes with a risk of overdiagnosis of patients whose cancer will never be clinically relevant for that patient. And it applies imagery, of course, and biopsy if something is positive. We only have 2 urologists in the country that can do that biopsy, and they're in the private. So maybe early diagnosis is not as bad as we think. For example, in breast cancer, if you do a good clinical breast exam training of all your healthcare workers, and you create awareness in the public, then you do clinical breast exam only for patients who present with symptoms, then that on-demand clinical breast exam reduces stage at diagnosis. And we've seen that in studies in Rwanda and Eswatini. So it works. Is it just as good as systematic screening with clinical breast exam for everyone? We don't know. We should do a study on that. And we're thinking of doing it in Botswana. But of course, we see that 50% of those that we think we have to refer for further imagery or for fine needle aspiration actually don't get to doing that exam. So you need patient navigation to have the patient do what you want her to do. And you need to improve pathology to the turnaround time. So you can treat, so then you can treat your cancer that you've detected in time at an earlier stage. Well, cervical cancer, unfortunately, when there's symptoms, it's often a sign of a locally advanced disease, stage 2 or stage 3, when needing chemoradiation. It's very expensive. We also spend about $400 million only in chemoradiation in this country because it's done in the private. But still, if you can avoid stage 2, going to stage 3, you improve your mortality, you improve your survival. So you still need navigation and pathology around turnaround time that needs to be improved for those locally advanced diseases as well. So it avoids stage migration due to waiting for results delays. But let's not forget those other cancers, right? Kaposi, vulva, anus, and penis, particularly in those living with HIV. And for women that come for cervical cancer screening, look at the perineum. Because vulvar cancer is very frequent, and it's in very young patients, and it's very invalidating when it's too advanced. So every patient should have that exam when presenting for cervical cancer screening. If a lesion is present, go for biopsy, don't give creams. And brain invasive lesions can be any color. So the biopsy is the one that will tell you. Okay, we've early detected, but can we treat in time what we detect in time? We need to work on that. In Botswana, there's 4 cancer centers, but presently there's only 4 oncologists working in the public sector, and 3 of them are in the capital. So we need more people. We need more education on cancer. We need surgery. There's only 1 oncological surgeon in the country. We need radiotherapy, more radiotherapy. There's only 1 machine, and it's in the private. And we need treatment to be there where it needs to be. Hormonal treatment should be in any district hospital. People shouldn't travel for hours just to get tamoxifen. And it should be there. We have been out of tamoxifen for 4 months in our country. It's a $1 drop, right? chemotherapy stockouts. We are out now of adriamycin, cyclophosphamide, paclitaxel, cheap drugs, right? So we have to work on that whole issue of stockouts, not because of cost, but the problem is if not having it costs us more than having those $4 drugs. And we need to have survivorship support and supportive care. What's the point of having good chemotherapy schemes if a patient can't be treated for neutropenic fever in the district hospital? So you need education there in all district hospitals, and we're working on that. So we have, but there are potential solutions, of course. We have to plan about what I can't really make sure that we can treat what we want to treat. So we have to plan, and we have to be able to pay for what we plan to do. So we're working on a national cancer control plan with the help of WHO, very appreciated. And obviously, as Ben alluded to, we have the guidelines, but the guidelines have to be followed. They don't have to be in a drawer somewhere. And education. And we're working on a basics of cancer course that is ongoing now in the 4 centers, and we want to expand it to the district hospitals. So thank you for your attention.
Thank you very much, Peter. A lot of food for thought in your presentation, and I think it will be very good in the discussion. So I think we should move on, and I'll ask Francis to introduce the next speaker.
Yes, thank you. So I'd like to introduce our third speaker this afternoon. Well, at least it's afternoon in London. The third speaker is Dr. Philippe Reutberg, who's a medical oncologist and a World Health Organization consultant for cancer management and control based in Geneva in Switzerland. He completed his oncology fellowship in Sao Paulo, where he's worked for at least 10 years, has a strong interest in public health. And at the WHO, he's actively engaged with countries and partners, particularly trying to develop national cancer control plans and how you go from the plans to actually implementing them. So he's done a lot of work in Sub-Saharan Africa, as well as in Central Asia and Europe. So it gives me great pleasure to ask Philippe to give us his presentation.
Thank you, Dr. Francis, for your kind and gentle words of introducing me, and Dr. Fatima for having me, and all the panelists here and audience. I'd like to start celebrating the opportunity to discuss with such a distinguished audience of panelists to encompass what we're doing here in WHO for the main global initiatives. And I'll just ask you to please let me know if you can see my slides now. Okay, great.
Yes.
So I would like to encompass not only describing the WHO cancer initiatives that Ben brilliantly mentioned about the Global Breast Cancer Initiative, but also make sure we can address the topic for this discussion, which is related to sustainability that all the panelists also addressing during their points, and making sure we do not increase costs, but also reinforce the need for having quality care. So as the next slide, let me see. Oops. So first of all, the question and for this discussion that encompasses the whole discussion is about investment and about sustainability and the financial sustainability also. So why and when to invest in cancer? The question has an answer that's time to invest. It was yesterday, actually, according to the data that Dr. Pitti just showed and Ben also about Ghana. So what does address in the bigger scope of disease? Because the countries having competing priorities, I would say. We would like to have only one priority, but actually the countries are still facing the infectious disease and at the same point, the transition to increase the non-communicable disease in their scenario. And here, as you see in the graphic, cancer is also increasing more and more over the next years. And we should not keep just reinforcing the challenge of addressing cancer, but understand how this affects people's life. So we see that almost every family will be impacted everywhere. Why everywhere? 1 out of 5 person in low middle income countries will experience a cancer case in their families, and 1 out of 2.5 in high-income countries. So hardly someone that is listening to me didn't have the experience of having a friend or a family or a relative that had cancer. So this is a problem of all of us, and we should find solutions that are sustainable. And the word sustainable also addresses a commitment, which is a global commitment of sustainable development goals. And in this regard, which are the targets that also address cancer? The target 3.4 and 3.8, according to our global commitment, says that we should reduce the premature mortality by 1/3 by 2030, and also increase the capacity of countries to provide universal health coverage. So how far are we from this? Only 9 countries are on track to reach these targets by 2030, which is in 8 years from now. And we can understand that by financially improving efficiency, by improving the capacity of countries to provide quality care is not only enough, we need to increase our expenditures, at least from 0.6 for low and middle income countries in terms of their gross national expenditure per capita. 90% of the low and middle income countries would be able to reach their goals, but we need not only capacity in terms of capacity building, the right guidance in place, but also we need investments to make sure we can address this. And we have an extra challenge, which is COVID. We understand that COVID for many of us was around 1 year ago, or now a new wave is coming. And the deaths by COVID reduced, the mortality related to COVID, the total mortality directly related to COVID reduced. But what about the disruptions? As you see here, 79% of cancer screening are still disrupted, according to a WHO post survey that has been conducted only a few months ago. And for cancer treatment, 68% of the countries referred disruption in cancer treatment. So we still have a lot of disruption happening everywhere. What about our response to this? In terms of NCD's emergency health preparedness and the plans to tackle COVID, only 38% included cancer in their plans related to the emergence of COVID. Only 3% out of 87 countries that responded a budget line for NCDs. And only 10% have a strategic guidance of how to implement access to care and treatment related to cancer, to NCDs, in their agenda. So we're still lagging behind with this huge challenge that, as you see here in terms of life, we have 5.4 million direct deaths related to COVID, but 14.9 million excess mortality, which is mostly related to the disease, not COVID, but the disruptions in the healthcare system that have been expressed previously. And if you project these numbers, probably the time to invest in cancer, again, I will reinforce, is now. Otherwise, if you do not include the mitigation strategies, plan, budget, we're going to see these numbers increasing over the next years. So in terms of mid, long impact, the social impact and economic impact also are related to the reduction and trust in healthcare system from the citizens, increasing structural inequalities, increasing risky behaviors as tobacco, as alcohol consumption that Peter gently and brilliantly mentioned before me. In terms of economic impact, we know that economic revenues are reducing, the health expenditure in cancer specifically has been reducing, and the funding by NGOs also has been reducing, as you see here in this graphic. Also, the general government gross debt per income group has been increasing a lot across every income level, as you see here, especially remarkable for low and middle income countries. This means that more than 70 low and middle income countries has an extra debt of $11 billion from 2020 to 2021, an increment about 45%. And mostly we're speaking about people, 50% of the households would struggle maintaining basic levels of consumption beyond 3 months. So it's urgently needed financial protection. And you might ask, Felipe, but what about the WHO role and the global initiatives roles in that? How WHO assumes they will have help shifting the current approach to make sure we can address and improve our current capacity to provide cancer support. So we act through 3 main functions in leadership: norms and standards, which we can describe as guidance, and technical support. Through 3 integrated WHO cancer initiatives, and I'll reinforce here the word integrated as I'll show you, convening stakeholders through global forums and cancer center networks, encouraging coordinated action. For forging partnership with more than 300 implementing partners across all regions, including UN agencies. And again, stressing the value of speaking to the selected audience. You are these partners that we expect to keep working with you and leveraging this agenda. More than 15 different guidance have been produced over the past years in terms of products and driving innovation. Co-creation of products with people affected by cancer, and in terms of technical support, more than 70 countries are now supported by our team from 2019 to 2022. But it's not enough. What we want to reach, what are the goals that the global initiatives setting, so you can understand how can you do better and what's your goals. In terms of global initiative for childhood cancer, we know that only 20% of children will survive in low and middle income countries due to resources and the capacity to treat these children. So we have a goal, a target of 80% of children will survive in high income countries, and we set this target to 60%. So it's a feasible target based on evidence-based. It's not assumption, it's evidence-based. A target for at least 60% survival to save 1 million lives by 2030. In terms of a global strategy to eliminate cervical cancer, we have set up as a target that 90% of the girls fully vaccinated with HPV by 15 years of age, 70% of women screened with HPV tests at 35 and 45 years of age, and 90% of women identified with cervical disease receive treatment for precancerous lesions of invasive cancer. So we have well-defined targets to reach by 2100. And in terms of the Global Breast Cancer Initiative, Brent just mentioned again, the idea of the pillars for the Global Breast Cancer Initiative, which is health promotion, through early detection, increasing the early stage disease detection of 60% stage 1 and 2, timely breast cancer diagnosed to treatment, to reduce time to diagnose until 60 days the patient to receive comprehensive treatment, and comprehensive management, increasing coverage to make sure 90% of the women are treated and have their treatment completed. By reaching these targets, we expect to reduce mortality by 2.5% a year and save 2.5 million lives by 2040. It might look ambitious, but all these targets are evidence-based and they are related to what we understand can be done. And we have been dialoguing with countries, with national authorities, with WHO regional offices and partners. But here, I'd like just to reframe how can we do better? Because we know that the resources are constrained, the fundings are reducing, so we need to increase our capacity by integrating initiatives. So as you see here, the idea that is the initiatives are stand-alone in the healthcare system and the way they will provide them or support them is not necessarily true. Actually, what we've been working is a way to integrate the cancer initiatives through these main dimensions of governance, cancer information system, access to cancer products, WHO workforce to dialogue, service model, the delivery model, and financing. So we might do better because we cannot work in isolation in silos. And as you see here, we recently launched as a team the non-communicable disease facility-based monitoring guidance. I would suggest everyone here in this call, if possible, to take a look in the WHO website. It's a way to empower the community, it's a way to empower the managers and to make sure we are doing better in the primary healthcare level. So as you see here, internally in WHO, but also with UN partners, we are increasing our capacity by expanding our partnerships and understanding what everyone in this game can do better. So you see here, radiotherapy, for example, can increase capacity by the mandate that IAEA has, collaboration with HPV vaccines with Gavi, HPV tests and secondary prevention with UNITAID and UNICEF, so we can do better for the countries that already have been discussed here and mentioned before. But let me please enlighten you about how this happened. Most of us ask, well, but fine, this is beautiful, but how does it happen in the real world in practice? So how WHO support the countries? Through policies formulation, to acceleration implementation and measuring impact and drive innovation. And here we use the priority strategies based on the WHO situation analysis, and Ben mentioned the relevance of having a situation analysis before making sure you will propose any specific initiative for screening or increasing capacity. So where are you now? To convene partners in national policy dialogues through stakeholders map, and initial outputs using normative WHO documents and tools. I would here cite, for example, the national treatment standards that been mentioned, workforce optimization training, the cancer center planning, but also the investment case that we are now supporting countries through costing and health impact analysis for the national cancer control plans. So the next step is to support governments and partners for action. So after the assessment, how can we make this? By enabling implementation plan, including quality of care, which is the topic, main topic for this discussion, mobilizing resources through the benefit package selection and the proper investment case, supporting medicines and proper procurement that Peter just mentioned, what happens in his country. Now, the challenge not only of having medicines, but making sure the whole chain of value for medicines is in place, so we don't face stockouts or problems with procurement. Even though the drug is cheap, we must make sure we have the whole value chain addressed. Strengthen registering information and systems, and as I mentioned before, measuring impact and drive innovation. So Felipe, can you please just provide some examples what has been happening in the field? Sure. Here as an example for the Global Childhood Cancer Initiative, considering the current strategies and the current goals that we set, how are we supporting countries? Now we have more than 60 countries through 4 regional networks in partnership with WHO. But not only the countries in WHO through the WHO country office and WHO regional office, which are in the end of the day, the instances related to implement and to coordinate with countries, how can empower them through these initiatives in technical documents and guidance. So we have now more than 120 partners involved with WHO Childhood Cancer Initiative, not only UN agencies, not only WHO or government. So you that are listening to me now, you're a potential partner, make sure you can engage and improve your reality in wherever you are. 10 priority actions through cure-all approach for investments. And I'll cite here as an example, concrete example, a showcase, a global partnership for childhood cancer medicines.
So sorry, Philip, to interrupt you. There's 2 minutes left, please.
Okay, I'll finalize my presentation. So as an example here, we set up the idea to cover universal sustained access to quality assured essential cancer medicines for all children in low and middle income countries. The outcomes is to improve affordability, availability, accessibility through quality assured medicines. Through a $200 million donation from St. Jude and a strong partnership with WHO and partners, we defined now countries that are in a phased manner, 4 phases. And in this first phase, we already have 12 countries related and now actively engaged to make sure all children have access to quality care with also an affordable and quality care related to cancer medicines through a procurement process supported by WHO and St. Jude. And just to reinforce here the last value of our discussion here, how can we frame also for the cervical cancer initiative? We are increasing the pre-qualification to make sure we can reduce the cost for vaccines to be available, and how can we optimize the use of resources through e-learning courses for the cost analysis, through workforce training material. And last, and but not least, we are generating investment models for the countries, so we know how the investment might return in terms of values of life and quality of life and expectations. So the last point I'd like to cite here is that our overall measure for success is empowering the community and people living with NCDs and cancer. Thank you for the opportunity. It's been a pleasure. Over to you, Dr. Fatima.
Yes, Philippe, thank you very much for that presentation. I'm sure there'll be lots of questions at the end. You know, you highlighted for me the importance of leadership in achieving these goals, and also a collaboration between the different agencies. And the other thing I'm sure will come up is where are we now in terms of reaching some of these targets? we hear quite a lot about the 1.5 degrees centigrade and the climate crisis, and we know where we are behind where we should be at this stage. Be interesting, perhaps we can discuss where are we in terms of some of these targets. So I'd like to hand over to Fatima to introduce our full speaker. Thank
you very much. And it's my pleasure to introduce Dr. Zipporah Ali, AORTIC Vice President for East Africa. Dr. Zipporah Ali is the Executive Director of Kenya Hospices and Palliative Care Association. She is deeply involved in advocacy and creating awareness on pain relief and palliative care for both children and adults, as well as advocating for palliative care to be integrated in the cancer care, but also in the training of both medical and nursing schools in Kenya. So it's our great pleasure to listen to her thoughts about organization of supportive palliative care and end-of-life care. Thank you.
Thank you very much, Dr. Fatima. I don't know if I pronounced it the way you said. Yeah. Yes. So, thank you very much for this opportunity to the AORTIC team and everybody else in this session. I want to just correct something. I am the former executive director. I retired last year in May. Currently, I chair the NCD Alliance of Kenya, and I work as an independent consultant since I retired. I don't know if you can my slides be seen? I put them to PowerPoint.
Yes.
So I just want to thank the previous speakers. I think they have spoken quite a lot on very, very important issues. The issue of, I think for us in Africa, the issue of early diagnosis, not even just early diagnosis, even presentation, diagnosis, all those things affect our patients. It's not necessarily that our patients come late. Sometimes they come to us early, and then we don't have very strong health systems. Though I think in Kenya we have improved a lot in the last 10 years in terms of being able to make early diagnosis and treat patients timely. But if I start, I think somebody's playing in my, is it me or somebody else? If I start this presentation, I usually say that it's good to remind people what palliative care is, what supportive care is, because a lot of times people think palliative care is end-of-life care. They think when a patient is dying, and I've seen that working as a palliative care doctor for many years, is my colleagues will wait until the patient has a few days, weeks left, and then they send the patient to the palliative care teams, which is really wrong. I just want to remind us that palliative care is defined by WHO. It starts at the time you make a diagnosis, throughout the illness, and even through survivorship and end-of-life care. It's very important that we remember this. It's one of the things that we find is very challenging when we brought patients, because somebody feels there's nothing else they can do for this patient. We want to have the patients, when you make a diagnosis, so you can actually have a good impact on their quality of life, not just of the patients, but also of the family members. Supportive care is usually care. We talk about supportive care mostly as care that's given to help patients manage their illness. Somebody please stop moving my slides. I don't know if it's me or somebody else. To manage the side effects of the illness, of the treatment they're getting when they're being treated for their disease. So that is mostly focusing on minimizing or treating the side effects of treatments. And end-of-life care, of course, is part of palliative care. It's not an independent issue. It is part of palliative care, because palliative care is the big umbrella. And so end-of-life care is when the patient is approaching death, then our focus and goals of care change to focus mostly on quality of life and not necessarily on quantity of life. So when I was asked to talk on this session, in this session, I thought I've retired. I need to talk to those guys who are in the field now to tell me what they'd like me to talk about. And I shared with the colleagues that we're having this session. What would you like me to talk about? Palliative care, survivorship, end of life, supportive care, and all those things. And I got responses from them. For this presentation is really going to focus on what the healthcare providers, and in some of those forums, we had patients also who spoke what they think is important in terms of ensuring that people have access to quality palliative care. They have good access to supportive care during their treatment. And when they're dying, they have the best quality of care at a time when it's very difficult for the patient and the family, since death is not really something that's easy for anybody, no matter which part of the world you're coming from. And some of the things they said, somebody said that we should focus on education on palliative care skills and approaches, including better communication. And I think we all know that communication is one of the biggest challenges we have as healthcare providers. We don't know how to communicate with our patients in a very efficient and sensitive manner, especially when you're breaking bad news. And that really can destroy somebody's morals and even affect the way the disease will actually go. They talked about research, and they talked about research that is really supposed to be local research. I'll mention these things that are talked about: leadership, mentioned things on pediatric palliative care and survivorship, that it was totally ignored and not put into our policies. And so these are some of the things they talked about, and I'll come and just talk a little bit about some of them as I continue with this session. Awareness and sensitization was very mentioned quite a lot. Not just awareness, to the healthcare providers or, to the public only, but across, the people. If you're taking care of the community, the country we live in, patients and their families, everybody needs to understand what these services are, so that they don't just think that if you're sent to a palliative care center, it means that you're going to die. That's not what we want people to hear. We want people to know that it's about living, it's about quality of life. Yes, we will all die. The time that comes and we all die, but we should also be able to access the best care when you're dying. So awareness was highly mentioned. But apart from awareness, they talked about, they mentioned things like including even development partners, because it was felt that there's very little funding in terms of these services. Mostly people will fund, cure, but will not fund what else comes along cure, because we know palliative care and supportive care is actually given alongside curative treatment. So you find that somebody can access their medicines, the chemotherapy drugs, but is not able to access to their pain medication. So some of the things that we really need to look at, how can we have an integrated system where we take care of a patient holistically, whether we are talking about a curative treatment or palliative care. Universal health coverage was also very important, and also the issues that WHO has to, and I'm glad that Dr. the last one talked about WHO plans for cancer, which include palliative care, to recognize the importance of palliative care in all its strategies for cancer care. So education and research, I think most of us are aware that most of our healthcare providers don't receive adequate training in education. And so we find that patients really are not, do not receive the care they need to receive in terms of palliative, supportive, and end-of-life care, because the healthcare providers have not been trained to give these services. So one of the challenges we really want to see if we can improve, for us to improve care for patients, is to focus on education. And in Kenya, for example, I'll give Kenya as an example, because that's where I worked all these years. We have included this training curriculum, the core curriculum for undergraduate medical students, nursing, pharmacy, and clinical officers. And we would really like to see this being taught so that any healthcare provider, wherever they are, when they graduate, they're able to give these services to the patient as they look at the next place to refer the patient to. And one of the things we are doing with the government in Kenya with the National Cancer Control Program, the National Cancer Institute, is training primary healthcare workers in cancer care. And this has included also palliative and supportive care and end-of-life care, so that they understand how to support patients and their families. And so training is very important. It has to be an integral part of training of any healthcare workers and other people also involved in cancer care, because patients with cancer have got more needs, many needs. They have got their physical needs, emotional needs, psychological needs, spiritual care. All those things are very important. So we need to have a multidisciplinary training for better care for patients, and also issues of training in end-of-life care, especially in countries where we don't talk about death very easily, because we don't want to talk about death. If we don't talk about death, we'll be inviting death into, so we really have to do a lot of training and at the same time, even awareness for the public. In terms of integration, what was mentioned is that we need to integrate, we need to have politically integrated into, like I said, all training at all levels of care, not just undergraduate, but postgraduate as well. Have preceptorships, which are going on with the International Cancer Institute in Kenya right now. And also in terms of treatment, that's treatment for patients, treatments a cancer treatment center, you can't actually talk about a center of excellence, a comprehensive cancer center, if you don't have palliative care teams within that center, if you don't have people who can support patients through the side effects or whatever of the treatment they're getting. So we want it to be fully integrated so that patients can actually have a better quality of life. And others mentioned things like humanitarian conditions. Cancer does not just affect people within a formal setup, but we have people living in refugee camps, living in very different tough situations. They need also to be able to access these services, including family support. The issue of pediatric oncology, and I'm glad that the WHO is looking at really improving access to treatment for children, was also mentioned, because our children, and in Kenya, actually only less than 1% of the patients we see in palliative care or hospices are children, which means children are not really referred. So we don't know what happens to them when they're not really referred, but we need to also have pediatricians and people working in pediatrics oncology to understand that palliative care has a big role in supporting a child's, supporting a child during their illness and their family as well. The issue of early referral, I'll talk about a little bit about that. And I think early referral is very important. Like I said earlier on, from my experience when I worked at a hospice, people would wait until a patient has got a few days, weeks left, and they would send the patient to us and expect us to work miracles. We will do all we could, but it's actually better if you have a patient at an early stage, so you have good interaction, better symptom control, and all those things. So one of the things that we have seen in Kenya that has been a big problem is when our patients travel distances to come for treatment, they have no place to stay. Some stay in the corridors, sleep on the floor. We would really like, for example, for cancer centers to also have hostels or accommodation for patients and their carers at almost no cost, if possible at no cost at all. And of course, the different models the different models and settings that we can provide this care, whether it's within a hospital, a freestanding hospice, mobile, or or even in the home. Home care is very important. Respite care for the family are some of the things that were mentioned by the caregivers. So in terms of early referral, I want to really emphasize that it is very important. If we want to even cut costs on cancer care, we need to think about referring patients early. Most patients come to the hospital because they have a symptom. It's pain that brings the patient. They don't come and say, I have a cancer. They come and say, I have pain, or I have a swelling, or I'm constipated, or, I have this symptom. And if we are able to manage these symptoms effectively, which is possible, we can manage almost 75 to 80% of the cancer pain. If we are able to manage these symptoms effectively, these patients will not make regular visits to the hospitals. Thus, they'll spend less money going to the hospital. And also will not have patients in bed because their symptoms are not being managed properly. Most people don't understand how to use the WHO analgesic ladder. And so pain management is not done adequately, appropriately. And so we have all those challenges. Of course, early referral will mean patient satisfaction, family satisfaction, reduced caregiver burden. And of course, it has been shown studies have shown that those who receive early palliative care have less distressful symptoms towards end of life. And they even live longer, 3-4 months longer than the rest, or even more. This might not mean a lot to you, but it means a lot to the patient. So we need to think about early referral to improve our patients' care. So other things that we mentioned, that my colleagues mentioned, were policies. If you don't have policies, then governments don't really budget for what you want. So policies are very important. We've had palliative care in Kenya for 30 years, but we launched our first policy last year. So it is possible to launch a policy even 30 years after starting a service. So policies help in terms of understanding what you need to do as a country, but also even being able to look for funding within the government and others to be able to help you with what you want to do in your policies. So funding was a big problem. Everybody mentioned funding. We have been depending a lot in my country on outside funding, donor funding. Even working with the government hospitals, we had to get funding from outside to integrate palliative care into the public system. We need to have governments funding palliative care, taking it up as a priority and funding it within their own health budgets. But also, we would like to encourage development partners to commit funding to palliative care, just like they have committed funding to HIV/AIDS. Even patients with HIV/AIDS have cancer and they also need palliative care many times. So other things that were mentioned was that we should actually focus a lot on community-based palliative care. That means improving the education and the knowledge and skills of our community health volunteers to be able to support patients at the community level, and also care of the carers. People who are taking care of these patients can have burnout and many other issues, and we need to be able to address this as well. Of course, reducing stigma and demystifying palliative care. There's a lot of stigma around palliative care. There's a lot of stigma about dying. So we need to be able to deal with those kind of things further. In our own communities, and also training specialists. In Kenya, we have very few specialists in terms of doctors. I think there are only 4 of us, 2 of us are retired. We have others training right now. We have more nurses training, but we need to also invest in training specialists, because at times there are times when you need a specialist within a big hospital. That's when the other doctors will be able to listen to you. The community might not have specialists, but we need also to emphasize training in specialists and things like access, of course, to the necessary medications, especially the pain medications for relieving moderate to severe pain, the opioids that usually are a problem for many countries. So these are the things that my colleagues talked about, and I just want to share that in Kenya, we've actually done quite well. We have a national guideline for establishment of cancer management centers in Kenya, which has included palliative care, supportive care. You can't start a center without having at least a minimum of palliative care trained nurse in the center. We also have the Kenya Cancer Policy, which has also mentioned palliative and supportive care. I'm not saying end-of-life care, because end-of-life care is actually part of palliative care. And then we also have the National Cancer Control Strategy, which has also a pillar on treatment, supportive and palliative care. And we also have many other things that have actually mentioned these services. So I think we need to ensure that whenever we are talking about cancer, we have these services integrated into what we are talking, or what we are writing, or what we are developing. We have to make sure that we have included these services. Others, they'll be neglected. So that's what I really wanted to share, because that's what, when I asked people, what would you like me to talk about, this is what they talked about. And I think it's very important that we remember that we cannot really have a cancer, center of excellence, or even a cancer center that does not have palliative care or end-of-life care or supportive care, because these services enhance the quality of life of our patients and their families, and support them throughout the journey, the continuum of care, from the beginning to whatever the journey of the disease is for this patient. So thank you very much. That's what I will share with this evening. Thank you.
Thank you so much for this excellent summary. Thank you. And totally agree with you. It's impossible to have good quality cancer care without proper integration of palliative and supportive care. So we are going now to have about 15 minutes for discussion. We had several comments in the chat, mostly thanking all the speakers for wonderful talks. But I'll take one of the comments and perhaps address to Ben. So one of our colleagues from India is saying that in India, 5.5 million people have been pushed below poverty line due to high expenses of treatment of cancer. Perhaps in here, the prioritization of where to invest, and where to invest also out of pocket expenditures, is extremely important to avoid this going below poverty line.
Well, it is an extremely important point that I think we tend to sort of skip over. And the paper that I showed in the talk that we published in Lancet Oncology a year ago shows that if you don't provide for the services, you will not see an improvement in mortality. So I think part of the message, ultimately, this is in the control of the ministries of health and the ministries of finance. It has to come from within. But the idea that if you don't provide for payment and everyone is paying out of pocket, there is no example of a country that's reduced cancer mortality that has a pay out of pocket system and for treatment. And for reasons that everybody on this meeting knows. And I think we just have to say it out loud and say, if we don't have this, don't think your numbers are going to get better. They're not going to get better. And in the same breath, access and funding. And it's a grim story, and it's not limited to India. This happens in the United States as well. The number of families that become bankrupt because of healthcare expenditures is, for such a wealthy country, it's incredibly disappointing. And that it's why we do have to keep this on the prioritization scheme.
Thank you. And just highlighting also in Europe, this is a big problem and also an issue of inequalities, because the percentage of out-of-pocket care is so different from country to country, as well as it is different inside each country according to what the patient has as health coverage. So we should, as you say, keep on highlighting that this is something, if not solved, we will never solve the issue of quality of care. I don't know if any of the other speakers will like to add something to this comment of our colleague in India.
Fatima, may
Yes,
I?
please.
One of the things that we've been mentioning, Ben has leading an incredible job also. Soon I'll just do a spoiler here. We've been supporting breast cancer and cervical cancer, a dialogue with a country in sub-Saharan Africa related to what Ben mentioned regarding best choices, if now it's time to start with screening or phase it manually your provide your investments and make sure you use the better your resources. So it's about prioritization, it's about forecasting the investments and making sure they have your right and trained workforce. But as you said and Ben said, without financing and planning for finance, it's not possible. That's why we've been now supporting at least 4 countries to make sure through a proper dialogue we identify the priorities and let them know what their choices represents in terms of what they need to provide and how much that would cost in 1, 2, 3, 4, or 5 years. Without financing, there's no matter. Just to finish, only 9% of the countries in the National Cancer Control Plan, you have any consideration related to financing and funding, which means that you have a burden of disease that's a challenge, and you have a costly disease to treat, but you don't know how much that would cost you. So this is a starting point for this discussion related to how can we finance universal health coverage. Over.
Thank you very much. And perhaps taking your one of your comments, I would go to Peter, because you said sometimes governments don't know exactly where to invest, and sometimes they do invest on something that seems very good, like screening, when in fact that's not at all what you need in your own country. And Peter, perhaps going back to you about detecting early and treating as early as possible, but that is not equal to screening in a country where most cancers are symptomatic. Perhaps you want to reinforce that message.
Yes, thank you, Fatima. So first of all, for cervical cancer, that's the first cancer we have to go to for screening, because that's where the most benefit will be. Also cost effectiveness wise, as I said, chemoradiation is very good, but it's extremely costly and it can only be done in a few centers. So that's the one thing. The others, we only have to do it when we are ready for it, when we can give the care, when we can organize it so that it is equitable and for everyone. So as long as we cannot do it, we have to detect early, because detection of early is so much better than not doing anything. So for example, clinical breast exams, when the patient presents with symptoms, it's so important, so important. So that's why I'd like to insist on that. And cost effectiveness it's a no-brainer, right? It's so obvious. Concerning drug costs, as you rightly say, it's not about only planning the finances. It has to be done, and the price has to be set so that people don't increase the prices as we go. But also, for example, if you have the budget, Botswana is investing 40 times more in HIV drugs than in cancer drugs. So the budget is there, but it's just the access to it, the paperwork, the conflict of interests, all these things. The fact that a basic drug doesn't give much benefit to the ones that sell it compared to the newer drugs. All these things have to be put into the equation. And once we get there also, and we get better treatment, then we can go and invest our money in screening programs.
Fatima, could I add one thing about clinical breast exam to this, which is it got a bad name, that CBE, and the reason was because studies were done in the US and Canada that didn't see a mortality benefit to the use of clinical breast exam, but the part that was left out was that's in the context of mammographic screening. So the conclusion of that was adding CBE onto mammographic screening, which is women 45 to 74 at best. That's where it doesn't add. However, we have a study from Peru that looked at women who came into the cancer center in the northern part of the country in Trujillo. And the women that had had a prior clinical breast exam, somebody had done one at some point in the past, were more likely to come in with earlier stage disease and sooner in time. And the conclusion that we drew from that was there's an educational value to doing a clinical breast exam. It gives the woman an idea, what is it that you're looking for? You put her in position and you examine her. And we sort of forget about that part, that we're trying to, what is awareness? And doing a clinical breast exam is a component of that. It's not just a narrow diagnostic study in the way that we tend to describe it. Thanks.
Yes, thank you. And I just wanted to take that to highlight and perhaps even, kind of raise awareness to everybody who is listening to some interpretation of data that we sometimes listen to in many conferences. People who are looking into the data tend to interpret their data to their own context, instead of interpreting the data in the context where the data was collected or the trial was run. And obviously, if you look at a high-income country where they have a population screening program where more than 60% of breast cancers are stage 1 or 2 at diagnosis, it is very different when you take whatever study and you apply it to a country where 80% are symptomatic, locally advanced cancers. And obviously, you know that there are discussions even about the value of mammographic screening. But again, because people are not looking into the context of each country. So whenever you listen to experts discussing, I think you need to call them to the reality that the world is much bigger than just the high-income countries, and that there are many other things that we can do that are steps that will lead, like in the resource stratified guidelines. You start with the basics, and then you will get to the optimal level of the guidelines one day, but you don't start building your house by the roof. I don't know, any other question or comment from everyone? I'm reading one of them. Yes, please.
If no one's going to comment, I'd just like to ask the panel we've spoken about breast cancer and cervical cancer, but prostate cancer kills more men than, say, breast cancer kills women. So I just wondered what's the various panelists' thoughts about, the concept of early diagnosis in prostate cancer, which is different to breast cancer, and that you can't feel a lump in your prostate. So if we're looking to reduce mortality from cancers, then how can we do that without kind of making big indents into prostate cancer?
Well, as Felipe knows, I'll talk when I don't know anything about it anyway. So I'm going to throw one of those out there. In the US, we did PSA screening. And what happened was we got this big rise in incidence, but we didn't get any improvement in mortality. And that's why we stopped doing PSA screening, because it didn't translate to a mortality benefit, unlike mammographic screening. And part of that is that, at least in our taking Fatima's example, this is, older men, hormone therapies do very well. And the cancer you're talking about, I think, is the prostate cancer of the younger men, that it's the more biologically more aggressive disease that really does need surgery or radiotherapy. And I have to tell you, I don't have a good handle on how to detect that. We've moved away from rectal exams in the US, And I'm kind of wondering if that was, maybe we need to put the finger back up where it's checking for the more obvious disease, that it's not the subtle little lumps. You're looking for masses, but gosh, somebody who has urological knowledge here would be really handy, because I'm not that person. Anybody else?
Yeah,
No,
just to
Francis is a urologic
So what
expert.
is the answer, Francis? Did you ask the question knowing the answer?
I don't know the answer. I hear what Philippe has to say.
no, I prefer listening to you, Professor. You're the most qualified person here. I'll be wise and listen to you first, please. The floor is yours.
Peter, do you want to say anything about the prostate issue before I?
I'll go after you. I'll be wise and listen and learn from you, Professor Francis, please.
So a lot of these cancer patients with prostate cancer, they half of them actually have symptoms which are similar to the ones that have when you have with prostate hypertrophy, right? So, but it's only half of them that you will detect, or even less. But it's already better than nothing. So I think we have to create awareness about that, and that's what we do now in the Movember movement, is to create awareness about those symptoms, because the symptoms have to be treated anyway, whether it's cancer or not. So better create awareness about it. And then going back to that finger, yes, but the problem is also like, who will do it? I mean, is it also culturally acceptable? All of that we don't know about that, and there's probably some issues that we have to figure out before we start doing that. And again, we will only detect only about 40% of all those prostate cancer by just doing a digital rectal exams early enough to be able to treat them curatively. So, but it's better than nothing. But it wants quite some reflection before we start doing it.
Yes, I think we need to apply our collective minds to us poor men who I think are getting left behind in terms of cancer control.
Mm-hmm.
Professor Francis, if I may add just one point, as we are discussing prioritization to make sure we left no one behind and making sure we have the priorities addressed, as you know, in many sub-Saharan African countries, the likelihood of developing prostate cancer is higher than general Caucasian population. It doesn't mean that necessarily should do screening for everyone. And I'll use the same approach that Ben Anderson has been defending to make sure your healthcare system prepared to detect, refer, and treat on time. So then whenever you start screening, you make sure you're not doing overdiagnosis and not conducting the patient to what we expect ought to happen. So this also deals with out-of-pocket expenditures and unnecessary procedures and low-quality based diagnosis and treatment. So I think the likelihood of harm is not even better than nothing. It's really higher as compared to what we expect to achieve, considering the low benefit at the moment. So we're not against. We're just understanding how can we make sure we are not undermining the capacity of detecting and treating and not harming the patient, but not the opposite. I would say just the way to frame your answer. Over.
Yes, no, thank you very much for that, because we don't have the answers. So I was interested to see what the panelists thought.
So maybe because we're reaching the end, so maybe just some comments that have been put in the chat really reinforce the messages that Zipporah alluded to. So the importance of raising awareness and educating and training about providing supportive and palliative care, and not just referring at the end of life. And so I had a question to Zipporah just about so we all know that, and Ben says this all the time, that morphine is quite inexpensive, but we still see a lot of deaths in pain in many regions of the world. So in your experience, from your practical experience and years of experience, what do you think are the major barriers to proper pain control? And so addressing the barriers could perhaps help us address this terrible issue in cancer care.
Thank you. That would really need like a whole hour talk about it. But I think I'll just mention that the barriers can be divided into a number of issues. first, healthcare professionals barriers, because people think patients will get addicted, so they don't prescribe. They think patients will die. So we need to do a lot of training for our healthcare workers to understand how to be able to assess pain and manage it appropriately, using the WHO recommendations. The other, and I won't go into details, but I think one of the biggest barrier that I came across was healthcare professionals. Then we also have barriers that are also patient barriers. Patients also fear to use opioids because they think they'll be addicted. They also think they'll die. We also have legal barriers in the countries where we have restrictions on opioids. In Kenya, for example, before we started doing advocacy, our law used to say that if you prescribe an opioid and a patient dies or reacts or something, you'll go to jail, or you'll pay $10,000, penalty. And so nobody wanted to prescribe. And then even the prescription has to be done on 3 pads, and a lot of writing, and people just don't want to do all this. They don't have time. And also how you store the morphine. In our pharmacists don't want to keep it because they have to have a proper storage with a strong door, with iron strong door, and so all these things complicate. But I think the issue of I think we need to work together to address all these barriers, because even if you address one, you can't really succeed. You have to address whether they are legal barriers, professionals barriers, patient barriers, supply chain barriers, because in Kenya, we are allowed to have morphine. The government is buying the morphine. We are dispensing it through a government system, but we do have stockouts also. So the supply chain issues can also be a problem. But I think we need to also encourage our patients to talk about their pain. They don't usually talk about their pain because we have made in such a way that if they talk about pain, we victimize them as those guys who like to complain. So we need, in Kenya, we have started, we had a program where we used to ask patients, do you have pain? Talk to me about pain. We'd go around hospitals. So we need to encourage patients to know that they can talk about their pain as they talk about anything else. And pain has to be on the assessment form as a 5th vital sign. So we need to look at so many different barriers. But I think mostly, I always find healthcare professionals are my biggest barrier, apart from the legal barriers.
Thank you. And perhaps as a last comment to Ben and Philippe, since now we have Global Breast Cancer Initiative, a global cancer initiative for cervical, for breast and pediatric cancer, taking into account that many women go to the doctor together with the children and to lead them to have all this care together. Perhaps the next one should be on palliative and supportive care to raise this awareness about this important issue that is cross-cutting not just all cancers, but also many other diseases. So this could be a take-home message from this session.
It's actually very timely that you bring that up. We are talking about how to integrate. There are palliative and supportive care efforts at WHO, but they haven't focused on cancer. And so we're trying to figure out how to do this in a way that's not duplicative at a minimum, so that everybody's talking in a similar way. But we're trying.
Thank you. So I just want to thank everybody for their really excellent talks and excellent discussion. I also wanted to acknowledge that AORTIC President, Professor Rose Anurlu, has been joining us and listening. Thank you, Rose, for taking the time. Thank you, Francis, for wonderful co-chairing. And thank you, everyone, for sharing your life experiences from all these issues in your different countries. Thank you. And I don't know if you say good morning, good afternoon, good evening to everyone.